the same, but improvement in cutter machineries and illumination system helps us much. Now, my topic is talk about diabetic vitreomacular interface disorder changing paradigm. So we don't have any financial interest in this matter. Let's see what is happening in diabetes. There is non-enzymatic ligation of the proteins, degenerative changes in the vitreous. It occurs at a very earlier stage, which can produce anomalous PVD, and this anomalous PVD I will come to the later on. And now, what are the vitreous changes occurs in diabetic retinopathy? In diabetic retinopathy, the vitreous, there is progressive vitreous contraction now, even after successfully regressed PDR caused by PRP. If there is bleeding in previous stages, this further augments the contracted property of the vitreous that may lead to the all complications like tractional retinal detachments, secondary retinal detachment, persistent macular edema, premacular damage, all these things. Now, what is happening with anomalous PVD? And anomalous PVD, it can be partial thickness, which may lead to vitreoschisis, which may lead to epiretinal membrane formation. Ultimately, if there is centrifugal traction, it can lead to macular hole, and if there is centripetal traction, it can lead to macular pucker. And if it is full thickness anomalous PVD, it can lead to partial PVD. You should know that in diabetes, especially in diabetes, partial PVD is very common. Complete PVD is very uncommon. So this partial PVD can, if there is posterior traction is there and peripheral separation, it can lead to macular traction, which may lead to vitreomacular tractional syndromes, which is very common in diabetes, and progression of diabetic retinopathy, DME, and other pathologies like neovascular AMD. And if there is optic distraction, that may lead to vitreomacular detection. So full thickness separation, if there is posterior separation, but peripheral traction, it may lead to retinal tear formation, as well as retinal detachments. Now, diabetic vitreomacular interface disorder, which is best understood in OCT, these are the all vitreomacular problems we deal in our day-to-day practice. So this is the spectral domain OCT. It helps in morphological accuracy, absolute adjunct to plus 90D or 70D exam. It's more convincing for the patient. You see the pre-op picture like this. Multiple traction is there, and after surgery you can see the traction is not there. And if you give it a single scan, pre and post-op picture, it will be more convincing for the patient. So now coming to the vitreomacular adhesions. As retina and vitreous adhesions are typically remains at the site where the bonds between the vitreous and retina are strongest, including macula, it's referred to as vitreomacular adhesion. And what is symptomatic VMA? If these adhesions are very strong, abnormally strong manner, that can lead to that can produce symptoms due to vitreomacular traction, and subsequently lead to loss of vision or distortion in vision. This is the one OCT picture of symptomatic VMA. Now, symptomatic VMA, orsiplasmin ZTI is one of the treatment of choice. It's non-surgical procedure. I think Dr. Mahesh will cover this part. And now, what is the role of 3D OCT? 3D OCT, you can get, see the above there is two-dimensional OCT and 3D OCT, and you can see the focal additions. Whether it's a single focal addition or multiple focal addition, you should be very cautious during surgery. So 3D OCT, by which you can determine. So what are the approaches for to deal this kind of thick highlight phase, posterior highlight phase with VMD after doing good vitrectomy? Just see there is a lot of fibrous proliferation just parallel to the retina, and with the help of modern cutter, you can go very close to the retina. You can just with the saving mode, you can just save the whole fibrous membrane because the vascular part is not there. That's why the chance of bleeding is less. Another technique approach, it is proportional reflex phytodissection that modern constellation cutter have. You can separate by just get a fluid flowing through the port tip, and you can just pull it the whole detached highlight phase from the retina. This is another thing. In case of broad-based adhesions, you can see the taut highlight phase. You can use 24 gauge needle to give a nick over the highlight phase to create an opening, and you can just do that. It's very cautious. You should not touch the retina, and after making this opening, you can just pull the highlight phase gently without any secondary break. We should be very cautious in this kind of situations. You can see posteriorly macula is absolutely flattened. So another situation of dot highlight phase. After staining the highlight phase, we have seen the highlight phase not removing. It is not. We can't remove this highlight phase. So we have bent the 24 gauge needle to produce the nick, and just with the same needle, bent needle, you can lift the highlight phase from the surface of the retina, because this kind of situation may happen. The highlight phase will remain. If you are not removing it, it will remain as a macular plaque-like formation, lead to posteriorly DNA formation. So do good vitrectomy, do complete removal of all highlight phase. If it is thickened, stain the membrane and use these kinds of approaches. Now, role of 3D OCT also in decision making in extreme situation of VMT, tractional retina detachment can occur at the macula. So you can assess the macula by 3D OCT like this, pre-op picture, and I think that Ramandas will cover on the detachment part. But still, I am showing one approach of tackling this kind of macular TRD after doing a vitrectomy, do the PVD induction, and after the PVD induction, stain the ERN part with the help of triple glue. It's rated glue, 0.15% rating glue. It's do the good ERN removal, and as much as possible. Sometimes this ERN can be very sticky. It is very stick to the underlying ILM. So if you are removing ERN, you can remove the ILM also. So to confirm it, I have injected brilliant blue G dye to stain the residual ERN, residual ILM. That see this is ILM is also been removed along with ERM in the macular foveal part, central part of the macula. Just you can enlarge the remove the residual ILM. And you can finish the surgery, do the fluid exchange after doing laser like this. So in follow-up, you can see the pre-op picture is like this, and post-op picture, and 3D OCT is showing absolute flattening of the macula. So you did a good job. So this is another situation. So now come to the very challenging situation. It's a refractory diabetic macular edema. Refractory to prior anti-VEGF therapy, refractory prior anti-vitreoretinal steroid therapy, along with macular laser photocoagulation, and basically it is caused by the extensive breakdown of the inner and outer blood-brain barrier. So treatments are challenging, and good vitrectomy along with ILM removal, it is the maximum you can do in this kind of situation. You should know that vitrectomy removes the anterior-posterior vitreomacular traction. It removes vitreous crisis. A removal of osteoporoneal factors from the vitreous cavity is possible. It can improve the microcirculation and reduce the abnormally high macular blood flow, and improves the oxygenation inside the vitreous cavity as well as ischemic retina. You should know a little bit about diabetic ILM. They are actually quite different from the ILM. Normal ILM or whatever ILM you are getting in the macular one, they are intrinsically pathologic. There is thickening. Basically, this thickening is related to the elevated HbA1c, duration of diabetes and age of the patient, and there is cell awareness on the vitreous surface. Now, this is a case of refractory diabetic macular edema where I plan to remove the ILM because ILM removal facilitates removal of the residual posterior vitreous cortex. It ensures complete removal of posterior highlight phase, complete removal of residual transitional traction is possible, and it ensures improves oxygenation to the retinal tissue. It relieves anoxia. So with the help of engraving forceps model, Dr. Sena has already told, with the help of reshaper engraving forceps, we just peeling the ILM from the macular area as much as possible, and there is a great debate whether you should do the ILM peeling or not, but this kind of situation, refractory diabetic macular edema, people have seen that only vitrectomy doesn't suffice your treatment of choice, so you should peel the ILM and just see that the results are really encouraging. This is the pre-op and post-op picture, resolution of all large cystoid spaces, as you can see. Even in the M6 scan also giving the loss of cystoid changes, post-operatively, pre-op it was there, post-operatively you can see there is a loss of cystoid changes, so macula is absolutely flattened, edema has totally absorbed. Now coming to the epimacular membrane, in diabetic epimacular membrane, they should know that they are mostly multi-layered, consisting of predominantly fibroblast and fibrous So you should stain the ERM with the help of triton glue initially, and remove the ERM nicely, and you should not be sure enough that I have removed all the ERM is not there. So stain again with the triton glue. Now you can ensure that the ERM removal is possible, because in this situation I am removing the ILM, not ERM, and whatever residual ERM is there, it will be removed along with the ERM, along with this ILM. So ERM removal facilitates removal of visible tractional elements and reduction of macro edema. So it's possible. Now coming to the diabetic partial thickness macular holes, sometimes chronic macular edema can lead to partial thickness macular hole formation. So postoperatively you can see, and you can give the patient the single scan showing that pre and post-op picture is like this, so it will be more convincing to the patient. And now in extreme situation, diabetic macular hole can occur, and so pre-op scan was like this. The C after doing vitrectomy has stained the membrane, and there is a lot of vitreous crisis part. These are all the things that is responsible for the tangential centrifugal traction to create a macular hole. I have stained the ERM with the help of triton glue initially to remove the ERM, and as well as the vitreous crisis part was incompletely removed. I removed the ERM part also, but it was again not completely removed. Then I injected the brilliant glue G dye to remove the ILM also. That this kind of situation is really helpful for the patient. You can see with the help of removal of ILM, this complete removal of all tangential traction is possible, whether it is vitreous crisis, whether it is ERM, or whether it is ILM. All the vitreous tractions can be removed. So these are the situations you can deal. Thank you for your patient hearing. Now I should invite Dr. Jayanto Goa to tackle to managing the diabetic vitreous hemorrhage part. Is rational and an approach for vitrectomy. Is the director of the Saigas Hospital. Is a vitreoretinal entity in North India. I think people should know. Welcome, Dr. Manish. I think you are here. So thank you.